I think when you hear the word sepsis, there's probably a very specific kind of terrifying image that flashes into your mind.
Oh, definitely. People usually picture this massive, fiery, hyperinflammatory storm.
Right, exactly. Like the immune system is just in this chaotic overdrive, tearing through the bloodstream and attacking everything in sight.
Yeah, that's the classic pop culture understanding of it.
But what if the real danger for so many patients isn't actually that initial storm? What if the real killer is the devastating, eerie silence that follows it?
That silent aftermath is what we call immune collapse. And honestly, it is arguably the most misunderstood and, frankly, the most lethal phase of the entire condition.
Because they survive the shock, right? But then...
Right, they survive the initial shock in the ICU only to succumb days or weeks later to secondary infections because their defenses are just completely gone.
And there is this fascinating medical paradox that we're looking at today. We are doing a deep dive into a new 2026 review article in Cell Death and Disease. And they present this wild scenario.
It really highlights how complex this gets at the extremes of age.
Yeah, so picture this. You're standing in an intensive care unit. In one bed, you have an 80-year-old patient. And in the very next bed, you have an 8-month-old infant.
Complete opposite ends of the human lifespan?
Right. But at the bedside, their sepsis looks identical. Like both of them have miraculously survived that initial inflammatory storm, but now both are suffering from this profound immune collapse.
They're both incredibly vulnerable to things like, hospital-acquired pneumonia.
Exactly. But here's the crazy part. The biological mechanisms driving their immune failure are entirely different. I mean, fundamentally different.
Which means treating these two patients requires entirely different clinical playbooks. If you just apply a generic one-size-fits-all approach to an aged system and a developing system, you're going to fail one of them.
Or maybe even both.
Yeah, quite possibly both.
So whether you're a medical professional staring at these charts every day, or you're just someone fascinated by human biology, we're going to totally change how you view your body's defense systems.
It's a really eye-opening paper.
Let's start by looking at the shared pathway of destruction, though. Because before we divide our focus between the young and the old, we have to understand the crash itself, right?
Yeah, we have to establish what sepsis actually is today. The modern consensus, which is called Sepsis 3, defines it as a life-threatening organ dysfunction. But crucially, it's caused by a dysregulated host response to infection.
A dysregulated response, meaning it's not the bacteria directly shutting down your kidneys or your lungs.
Exactly. It's your body's panicked, uncoordinated reaction to that bacteria that's doing the catastrophic damage. The source describes the start of this as early innate amplification.
Let's break that down. What does that look like on a cellular level?
Okay, so picture your immune system as having two distinct branches.
Yeah.
The innate system is your immediate, blunt force first line of defense.
Like the first responders.
Right. These are cells like monocytes and neutrophils. They aren't highly chained for specific pathogens. They just recognize general danger signals using pattern recognition receptors.
So when a massive infection hits, they just kind of panic.
They completely panic. They flood the bloodstream with massive amounts of signaling proteins called cytokines just to sound the alarm.
And that flood is the storm we always hear about. I find it helpful to visualize this innate immune system as like a Category 5 hurricane sweeping through a city.
That's a great way to look at it.
Because it's powerful, it's fast, but it is incredibly destructive to the infrastructure.
Yeah, and the other branch of your immune system, the adaptive system, ends up taking a massive hit.
Those are your lymphocytes, right?
Yeah.
The CD4 positive T cells and your B cells.
Exactly. They're your highly specialized, antigen-specific emergency responders. They are trained to take out a very specific target.
But the hurricane just wipes them out.
It does. The inflammatory and neuroendocrine stress from that innate hurricane is so unbelievably intense that it triggers massive apoptosis in those specific emergency responders.
Let's pause on apoptosis, because it's not just the cells getting battered to death by the storm, is it?
No, apoptosis is programmed cell death. The cellular environment during that cytokine storm becomes so toxic, and the stress signals are so overwhelming that your spiralized T cells and B cells literally initiate a biological self-destruct sequence.
Wow. They just dismantle themselves.
Yeah, their membranes bubble, their DNA fragments, and they quietly take themselves out. We see profound, sweeping depletion of these vital cells in human sepsis.
It's the collateral damage of the innate storm. But surely some survive, right? The hurricane doesn't get everybody.
Some do survive. But the review talks about a state called immunoparalysis for the cells that are left standing.
From what I gather, they're essentially exhausted. Like, they start displaying these protein markers on their surface checkpoint inhibitors.
Right, particularly one called PD-1.
And on top of that, your natural killer cells lose their ability to actually destroy threats. And regulatory T cells, which usually calm things down, actually multiply.
It creates a system-wide stall. The adaptive immune system is effectively paralyzed at that point.
I have to push back on this, though, because it feels completely counterintuitive. I mean, the body is actively infected. Pathogens are everywhere.
Yeah, it seems crazy.
Right. Why on earth would the surviving immune cells actively throw up a checkpoint inhibitor like PD-1 to put the brakes on themselves? That just sounds like a terrible evolutionary design.
You have to think about it from the body's perspective in the middle of that hurricane. That innate cytokine storm we just described is actively melting the host's own tissues.
Oh, so it's a triage situation.
Exactly. The lungs are filling with fluid, the kidneys are failing. The upregulation of checkpoints like PD-1 and the sudden expansion of regulatory T cells, it's a desperate evolutionary attempt to stop the tissue-destroying hyperinflammation.
The body is essentially saying, if we don't turn off the immune system right now, the inflammation is going to kill us before the bacteria even has a chance.
Bingo. The tragedy is that this safety mechanism often overcorrects, resulting in a lethal suppression where new opportunistic infections can just sweep right in.
So it's a protective mechanism that swings the pendulum way too far into the danger zone. Let's do a quick recap here to anchor this before we move on.
Sounds good.
So the early sepsis storm causes massive collateral damage. The stress forces your specialized immune cells to commit cellular suicide, and the surviving cells hit the emergency brakes to stop the tissue damage, which leaves you utterly defenseless.
That's the crash in a nutshell.
Imagine how your body feels after a massive, life-altering physical trauma. Now imagine that on a cellular level. What happens when your biological reserves are already empty before that trauma even begins?
And that paints the perfect picture of our first extreme of age, the elderly patient. We call their specific trajectory restoration failure.
Let's dig into that baseline, because an older adult doesn't enter the ICU with a pristine immune system. The review outlines this concept of immunosenescence, specifically highlighting inflammaging.
Right, inflammaging. It's a state of chronic low-grade inflammation that exists in older adults before any acute infection ever hits. Their baseline immune system is already kind of simmering.
But the real structural issue comes down to anatomy, doesn't it? Specifically something called thymic involution.
It does. The thymus is the key here.
Just to clarify, the thymus is this little gland in your upper chest, right? It's basically the training academy where new T cells go to mature.
That is exactly the right way to think about it. But as we age, that thymus shrinks. The functional tissue is actually replaced by fat.
Wait, really? By fat?
Yeah. By the time you reach old age, the thymus has essentially shut down production of new, naive T cells.
Naive T cells being the blank slates. The fresh recruits waiting to be programmed to fight a new threat.
Yes. In the elderly, that reserve pool of blank slates is effectively empty. Because the body can't make new cells, the immune system shifts its entire maintenance strategy.
Towards what?
Toward keeping old antigen-experienced memory cells alive.
Which leads to this wild phenomenon in the text called memory inflation. The review points specifically to a latent virus called cytomegalovirus, or CMV.
Yeah, CMV is a massive player here. Over decades of life, the elderly immune repertoire becomes completely dominated by these late differentiated senescent cells.
They even carry specific biological markers that doctors can see, right? Like they lack CD28 but express CD57.
Exactly. The mechanics of this are fascinating. The aging immune system becomes hyper-obsessed with old sleeping infections like CMV.
It just hoards its resources.
Pretty much. It commits a massive percentage of its remaining finite cellular resources just to keeping this old virus in check. Because of that obsession, the overall immune repertoire narrows. It loses all its flexibility.
So let me see if I can map this out with an analogy. It's like a massive city library. Let's say this city stopped giving the library funding to buy new books decades ago.
That's the thymus turning to fat. No new blank slates.
Right. So to keep the shelves full, the librarians just kept printing thousands and thousands of copies of the exact same old book about CMV.
Oh, that's good.
So when the sepsis hurricane comes through and burns half the library down, you're in real trouble. You have this low reserve, low recovery biology.
That is a brilliant way to visualize it. When sepsis causes that massive wave of cellular suicide, the elderly patient might survive the initial shock, but their library cannot be rebuilt.
Because the naive cells simply aren't there to replace the dead ones.
Exactly. And those surviving CMV-obsessed senescent cells proliferate very poorly. They offer almost zero help against whatever new hospital-acquired pneumonia is currently invading the patient's lungs.
So to summarize the elderly predicament, a low immune reserve plus massive sepsis-induced cell death equals a total catastrophic inability to rebuild.
That's restoration failure.
It really makes you wonder, if an elderly patient's immune system structurally cannot rebuild itself, how long do they remain vulnerable after they finally leave the ICU?
It's a terrifying thought. Months, sometimes longer.
But now we have to completely flip the script.
Yeah.
We're moving from an aged system that cannot rebuild to a brand new system that is still under construction.
Right. We're looking at the pediatric baseline now. The review refers to their specific trajectory as developmental derailment. And to understand it, you basically have to throw out almost everything we just discussed.
Because neonates and young infants are absolutely not just mini adults.
Not at all.
Their baseline is defined by immunoimmaturity. Where the elderly have an empty pool of naive cells, a young infant's adaptive immune compartment is completely dominated by a massive ocean of naive lymphocytes.
They have all the blank slates in the world, but virtually zero antigen experience.
And more importantly, those blank slates have a strict developmental bias, right?
They do. Early in life, the human immune system naturally leans heavily toward what we call a Th2 response.
Which is a tolerance-prone state.
Yes. The regulatory networks are still actively evolving, and their B-cell germinal centers, the physical sites in the lymph nodes where antibodies are refined, are still maturing.
I want to pause on that Th2 tolerance bias for a second. Because why would a baby's immune system default to being tolerant instead of aggressive? You'd think they need all the protection they can get.
It's actually an essential survival mechanism. Think about it. An infant is growing at an explosive rate. New tissues, new proteins, new cellular structures are forming constantly.
Okay.
If a baby had a hyper-aggressive, adult-like immune system, there's a massive risk that the immune cells would misidentify those rapidly growing tissues as a threat and attack the baby's own body.
Oh, wow. So it would cause an autoimmune disaster.
Exactly. So the system defaults to tolerance to allow for safe growth.
And they rely heavily on borrowed immunity to bridge the gap in the meantime. Like maternal IgG antibodies transported across the placenta and antibodies from breast milk to help shape their immune tone while their own system slowly figures things out.
That's exactly right.
So what actually happens when the massive hit of sepsis lands on this highly plastic developing system?
It completely derails that delicate developmental timeline. The massive inflammatory event forces rapid, unnatural shifts in the immune pathways.
The review mentioned a specific syndrome for this, right?
Yeah. It leads to a condition gaining widespread recognition called PPICS, pediatric persistent inflammation, immunosuppression, and catabolism syndrome. The entire maturation trajectory is violently thrown off course.
Now, here's where I hit a contradiction in the text that I really need you to clarify.
Okay, what is it?
The source explicitly states that children with severe sepsis show the exact same exhaustion markers, specifically that PD-1 checkpoint inhibitor we talked about earlier, as adults do.
They do, yes.
So at the bedside, we are looking at the exact same protein on the cell surface. Why is the review telling us this isn't the same biological phenomenon?
This is where understanding the biological context is absolutely everything. In children, those markers do not automatically equate to exhaustion from chronic antigen exposure.
Like they do in an elderly patient whose cells have been fighting CMV for 60 years.
Exactly. In a neonate, the upregulation of PD-1 might actually represent developmental restraint.
Developmental restraint. How does that work?
We go back to that safety mechanism for growth we just talked about. The infant's body is actively building itself. The immune system has these built-in restraints to prevent autoimmune attacks during normal growth.
Oh, I see.
So when the massive inflammation of sepsis hits, seeing high PD-1 in a baby might actually be a protective developmental program firing on all cylinders. It's frantically trying to prevent the immune system from destroying the infant's organs.
That is wild. It's not a sign of fixed maladaptive exhaustion at all. It's an emergency safety brake tied to their growth phase.
Precisely. It's the same marker, completely different meaning.
That completely upends how we usually think about test results. The exact same protein marker means a catastrophic cellular failure in an adult, but a desperate protective developmental safety break in a child.
It creates an absolute minefield for the doctors trying to treat them.
I can imagine. So, to recap the pediatric side, an immature developing system plus the shock of sepsis equals a profoundly disrupted immune development. If a baby's immune system is still actively learning how to tell friend from foe, what happens when its very first foundational lesson is a catastrophic system failure?
It's a huge problem, which perfectly transitions to the next massive hurdle outlined in the review.
Right, because if the elderly and infants have opposite biological baselines that result in the exact same immune collapse at the bedside, how does a doctor know what's actually happening in real time? You can't just guess.
You really can't. It all comes down to the clock.
Yeah.
We have to talk about kinetics and biomarkers.
Let's do it.
Historically, clinical trials for sepsis immunotherapies have been massive failures, and the review points out a glaring reason why. Trial designers enrolled patients based on a generic label of sepsis and measured their immune status at day 0.
Basically, the exact moment they were wheeled into the ICU. But taking a snapshot on day 0 is meaningless, isn't it? Because all you are capturing is the acute stress response. Everyone's immune system looks completely terrible on day 0 because the innate hurricane is right directly overhead.
Exactly. What actually matters is kinetics. Doctors need to look at day 2, day 4, and beyond. They are looking for persistence, the failure of the immune system to rebound after the storm passes.
To measure that failure to rebound, the review highlights 3 crucial biomarkers that must be tracked sequentially over time. Let's go through them. The first is ALC, or absolute lymphocyte count.
Right, ALC. A sharp drop in your lymphocytes on day 0 is a completely normal, expected stress response.
The collateral damage.
Yeah. But if you see persistent lymphopenia, a failure of those cells to return to the blood by day 4, that indicates true, dangerous immune failure.
Okay, so ALC is essentially just counting the raw number of troops left on the battlefield.
Simple as that.
But this second marker the review focuses on is a mouthful. MHLA-DR, monocyte HLA-DR. From reading the text, this seems to be more about communication. How does this mechanism actually work in practice?
Think of your monocytes, those innate immune cells, as frontline scouts. Their job is to find a bacteria, physically digest it, chop it up into pieces, and then present a small fragment of that bacteria on their outer surface.
Okay, they're showing off what they found.
Right. And the physical protein they use to hold that bacterial fragment up for the rest of the immune system to see is the HLA-DR molecule. By displaying it, they show the adaptive T cells exactly what target to attack.
So if MHLA-DR expression on the surface of the cell stays persistently low,
the scouts have lost their ability to communicate. They might be digesting the bacteria, but they can't show it to the T cells. The entire adaptive immune army is effectively flying blind.
Blind emergency responders. That is chilling.
It's very bad news for the patient.
And the third biomarker involves functional assays, which the text notes is especially critical in pediatrics. This actually involves taking a sample of the patient's blood out of the body, right?
Yeah, ex vivo testing. You hit the blood with a bacterial toxin like LPS in a test tube and measure if the cells can still produce an inflammatory cytokine signal, like TNF.
You are literally interrogating the cells to see if they are still physically capable of reacting to a threat.
Exactly. This kind of functional testing is what separates transient temporary suppression from deep, sustained, dangerous immunoparalysis.
Let's frame this with an analogy for the listener. It's kind of like judging a marathon runner. You cannot predict a runner's ultimate endurance based on their heart rate the exact second the starting gun fires that's day narrow.
Right, of course their heart is racing. They just started.
You have to check their vitals at mile 18, which is day 4, to see if their body is fundamentally failing to recover from the sustained effort.
That trajectory is exactly how immune monitoring must be designed moving forward. Serial testing over multiple days, tracking ALC and MHLA-DR persistence, and crucially, using age-calibrated baselines to interpret the numbers.
So summarizing the new rules of monitoring, it's all about serial testing, measuring the trajectory over days, and age calibration. If you're designing a clinical trial, you're looking at a terrifying tightrope walk.
Oh, absolutely.
You can't just give an immune-boosting drug to someone on day 1 of sepsis because they might still be in the hyperinflammatory phase. You would literally be throwing gasoline on the hurricane.
Which brings us to the final frontier, therapeutics. Once we have safely tracked the biomarkers over time and definitively confirmed a patient is stuck in persistent immunosuppression, they have failed to rebound by day 4, how do we biologically rescue them?
The review emphasizes biomarker-enriched trial design, using treatments based entirely on the patient's specific age and biological trajectory.
It's precision medicine.
Right. So let's look at the elderly first. The patients suffering from sustained immunosuppression because they can't rebuild their library. If their ALC, their lymphocyte count, is persistently low, the review points to a drug called IL-7.
Interleukin-7 is a vital growth factor. By administering IL-7, we can forcefully stimulate the surviving lymphocytes to expand and multiply. We're physically rebuilding the cellular ranks that were lost to apoptosis.
And if that MHLA-DR is persistently low, if the scouts are completely blind and can't present the antigen, what is the mechanism to fix that?
For that, we look to a therapy called GM-CSF. This is a powerful stimulator of myeloid cells.
So it targets the scouts directly.
Exactly. Administering it boosts that crucial antigen-presenting capability. It essentially forces the monocytes to push those HLA-DR molecules back onto their surface so the immune system can see the enemy again.
Okay, that makes sense.
And in cases of deep immunoparalysis, controlled use of checkpoint inhibitors like anti-PD-1 can be used to finally lift the brakes off those exhausted T cells.
I gotta stop you there, because the safety implications of this are immense. The patient originally ended up in the ICU because of a hyperinflammatory storm.
True.
If you give them GM-CSF to stimulate cells, or lift the brakes with anti-PD-1, aren't you risking reigniting that exact same deadly cytokine storm? How do you prevent a catastrophic rebound?
It is the single most critical safety question in sepsis immunotherapy. You prevent it through incredibly strict, uncompromising guardrails.
Like what?
First, you must have absolute source control, meaning the surgeons have physically removed the infected tissue or the antibiotics are definitively killing the primary bacteria. You cannot boost the immune system if the original threat is still raging.
That makes sense. What else?
Second, you only enroll patients who have serially proven over days that they are locked in the immunosuppressed phase. You are delicately trying to reignite a controlled burn in a dead forest, not start a wildfire.
That is a great way to put it. And what about the pediatrics? Can we use IL-7 and GM-CSF to rescue an infant's immune system?
With pediatrics, the review urges extreme caution. The primary goal in a child is not indiscriminate immune boosting. The goal is preserving their fragile developmental programs.
So no throwing gasoline on the developing system.
Exactly. Any use of these aggressive therapies in children is heavily restricted. The risk of permanently derailing their maturing immune system by forcefully artificially stimulating it is simply too high without more specialized pediatric data.
So to summarize the therapeutic landscape, we use IL-7 to force cell expansion, GM-CSF to restore the scout's vision, and cautious checkpoint blockade to release the brakes. But all of it is entirely dictated by the patient's individual biomarker trajectory over time.
We are completely moving away from treating the broad, generic syndrome of sepsis. We're moving towards treating the specific trajectory.
It is a monumental shift. It moves medicine away from treating superficial labels and toward treating the underlying biological reality of the patient in front of us at the exact moment they need it.
It really is the future of ICU care.
Let's bring this all together. Severe sepsis causes profound, life-threatening immune collapse across the entire lifespan. But we now understand the hidden mechanics. A persistently low lymphocyte count in an 80-year-old patient means a failure to rebuild an already aged, constrained system that is obsessed with old viruses.
Right.
Meanwhile, that exact same low count in an 8-month-old represents the violent derailment of a highly plastic, tolerance-prone, developing immune program. We have to stop looking at meaningless day zero snapshots and start measuring the immune trajectory over time.
The clinical presentation might look identical when you stand at the bedside, but the underlying biology demands age-stratified precision care.
Absolutely. But before we wrap up this deep dive, I want to leave you with one final thought, a lingering question to mull over regarding the pediatric side.
Oh, this is fascinating to think about.
We've explored how sepsis violently derails a developing immune system in the short term while they're in the ICU. But think about the long-term horizon. If an infant survives severe sepsis, how does that catastrophic biological reset secretly program their lifelong immune health?
Yeah, what are the decades-long consequences?
Right. Could a single episode of severe sepsis at 8 months old secretly alter their cellular memory, dictating their susceptibility to autoimmune diseases, the severity of their allergies, or even how well their body responds to a routine vaccine 40 years later?
The acute infection may be long gone, but the epigenetic memory of that early storm might just echo for a lifetime.
It is a profound and, frankly, kind of unsettling frontier for immune research.
It truly is. There is so much work still to be done.
Well, thank you for joining us on this deep dive into the silent killer of sepsis. Keep questioning the consensus, and we'll see you next time.